Good afternoon, everybody. All three of us sitting here were students of Dr. Bhaskar Reddy. Either of them were good students and I was a bad student. So naturally, Dr. Bhaskar Reddy used to like people like me more than good students. There was a mention that his interest in sports. His interest was beyond pathology. He is interested in everything around him. And right from whether we are coming in time or not, whether we came to the previous class or not, and he used to go out of the way to make sure that no sports person is ever failed in any examination, right from first year to final year. So that was what he was. I have many more stories about him, but some other time. And that Jayaprakash Narayan is one of the best students Guntur Medical College produced, and he didn't restrict himself to medicine beyond his graduation. He decided to take part in administrative services. He was one of the well-known administrative officers at that time, right from N.T. Ramarao garu to now. Later, in the later part of his career, he thought he should do something to reform administrative services and politics. That's how he started the organizations Lok Satta, ADR, etc. And then people used to wonder, why is he wasting his time being a doctor? What can he do? What can he do in politics? Why is he doing that? Many of us used to wonder. But going back, one of the father figures in pathology, called father of pathology, Rudolf Virchow, 1848, a German pathologist he was. You know what he said? Dr. Bhaskar used to quote him also. Medicine is a social science and politics is medicine on a grand scale. That's what Jayaprakash Narayan entry into politics made him make some changes in the way he brought out. I think his talk is well conceived, doing more and feeling worse, but at the same time, don't give up. Continue that. Thank you.
Sir, may I request Dr. Somaraj garu to present a medallion to Dr. Jayaprakash Narayan. I will request Dr. G.N. Rao sir also to accompany sir. Thank you very much, sir.
Friends, it's customary to say on occasions like this that I'm honored, but I'm genuinely pleased and honored. Thank you, Nageshwar, and thank you, Indian Medical Association, Telangana chapter. Because Dr. Bhaskar Reddy, for many of us, was a teacher, a lifelong mentor, and guide. And of course, for many of us who were students when he was principal, We were all incredibly young when we joined medicine, 15, 16 years old. Very timid, shy, scared, brought up in villages, in sheltered families. We had no clue about the world outside classroom or our village. He took us into his bosom, and he made us into what we are today in many ways. Many people called him like a headmaster. No, he behaved like a headmaster. I think actually he should have been a headmaster because we were incredibly small and very isolated and insulated. We required actually somebody who treated us like school kids, at least initially. He had a tough exterior, but he was very soft inside. I'm sure his family knows. It was like butter. I remember several occasions when, people were terrified of Dr. Bhaskar Reddy, but he was so gentle, so soft. During my undergraduate study, emergency was imposed in India. In many ways that changed my life. I was a very fierce critic of emergency. A lean, hungry-looking 54 kg fellow with no background, no pedigree, but very sharp in the views and uncompromising. And when some politicians were invited to medical school at the time for some of the functions, I went and protested. Why do you invite these fellows? They have no legitimacy and these are all half-baked fellows. He used to gently persuade me that, look, you have to understand life is very complicated. You can't fight with everybody. A lesson I have learned in life eventually. I remember how incredibly affectionate and inspiring he was. When we went for an intercollegiate quiz, the principal of medical college, whom we all know as medical graduates, we revere a principal and the superintendent of the hospital. They are like gods to us. The principal sitting not in his college but some other college, some other premises, in an intercollegiate quiz competition, she sat through it. When we got the award or the shield or cup or whatever, he received along with us and he dropped all of us in the hostel in his car. I still remember the kindness and the gentleness that a principal exhibited when dealing with his students. When he became director, in our system, Director of Medical Services is the apex of medical profession within the government. But he used to be so affectionate even as a director. Whenever he visited us, he used to put his arms around you and then make you feel very good and equal. Extraordinarily pleasant, extraordinarily decent, extraordinarily humane person. Post-retirement, after I moved to Hyderabad and he moved to Hyderabad of post-retirement, I used to ask him, Master, etla unnarani? Chala happy gunnanu Jayaprakash. Chala happy gunnanu. Pillanta settle ayyaru. Naku anta bagundi. Nenu inka practice chestunanu. Chala happy gunnanu Jayaprakash. There was never a complaint. No whining, no complaining. A genuinely happy person. That's possible only when you have come to terms with yourself. Your thought, word and deed, they are not all that separate. A truly wonderful and noble human being. I join everybody in paying my homage to his memory. A man who inspired hundreds of young people, young medicos, and shaped them into hopefully wise and effective men in the service of society. I chose a theme that I'm sure he would approve: doing better and feeling worse. And I've always, once I left village, I gave up on God. In the village, along with parents and others, typically Vinayaka Chavti or something else, we all used to do that stotras and story and this, that. Without knowing anything, it's part of our culture. We were all, I don't know if we were religious, but we were all part of the whole spiritual culture. Then I read Bertrand Russell after I went to college at the age of 13 to Loyola College Intermediate. My perception of God changed. I came to the conclusion that I was an agnostic. I have no clue whether there is a God or not, and it doesn't matter to me. It's one of mutual non-interference. Now, if God doesn't bother us, we will not bother him either. It's one of peace and quiet. But I believed then, and I believe now, that there is sin. You may not believe in God, but there is sin. And the greatest sin is avoidable suffering. Now, are we doing enough on what we need to do? Very briefly, we all understand the issues, so I won't take too much of your time. Let me place before you some ideas. Doing better, feeling worse is a title of an essay I picked up. It was written 45, 50 years ago in Daedalus journal. Daedalus, as you probably know, was in the Greek mythology, was a man of wisdom, of enormous erudition and knowledge and power. Icarus, who is better known because he tried to go to the sun and then his wings got burnt, was his son, Daedalus' son. So in the Daedalus magazine, journal, this title was written about American healthcare system in the 1970s. I thought that's very apt for us. We are doing very well. We are doing better. Look at AIG. Look at the remarkable expertise that we bring to the table today in the country. Look at the finest doctors who are a match to the best in the world. Many of them are sitting here in this audience. Look at the cost control, the frontier technologies and cutting edge interventions India is able to do at the fraction of the global costs without compromising on quality. Look at the pharma industry. A spectacular success. We are now more or less the manufacturer of drugs for the rest of the world. You only have to go to the US and try and buy something in a pharmaceutical outlet there to understand how incredibly inexpensive and good quality drugs we have in this country, how much we are blessed. Or vaccines. We produce most of the vaccines in the world. There's no dearth of human resources in the country. We produce, I think, 120,000 or so doctors every year and more nurses. There are about 15 lakh doctors, more than 15 lakhs registered. There are about 25 lakh nurses registered in the country. Another 10 lakhs or so are auxiliary nurses. So, and we can produce in a jiffy if you want more. We are doing very well. We are doing better. And yet we are feeling worse. Ask almost anybody in society about healthcare in the country today, you have litany of complaints. My appeal to the medical professionals here is, we have to take it seriously. It's not enough that we pay attention to the medical science part of it. As Dr. Somaraju mentioned, quoting FECO, we are not isolated from the rest of the country. Medicine is an integral, an important part of human life, but it's not the whole human life. And if society does not respect us, does not trust us, the society suffers and we suffer, the medical profession suffers. And right now, the trust is increasingly missing. For no fault of the doctors. But if doctors remain idle on this, if we don't pay attention to what's happening and therefore if we're not seen as champions of healthcare in the country, I suspect not only will the society suffer, but the healthcare profession also will suffer. And that's the context in which I'm trying to make a few remarks. We have seen the good part of it, feeling better. I briefly mentioned, you all know much more than I. But look at the other side. 50 million Indians, a full 5 crore Indians, descend into poverty every year on account of either lack of health care or healthcare costs that they cannot afford. 50 million is a big-sized European country. Only 2 or 3 countries in Europe are 50 million plus. Germany, Britain and France. 50 million every year descending into poverty, because we often think of poverty line as a stagnant one and the poverty is a stable concept. No, it's a dynamic concept. People descend into poverty, they come out of poverty. We only talk about the net numbers. When you talk about poverty being reduced, we take the net figures in a given year at a point of time. And on the margins of survival, a catastrophic illness or expenditure incurred or the property mortgaged in order to get health care. That makes all the difference between poverty and non-poverty. And our poverty line is a very low one. It's about 2,500 calories being consumed by a person. That's about it. 50 million people in Telangana and Andhra Pradesh, annually about 45 lakh, 4.5 million people descend into poverty on account of healthcare problems. Now, they have no reason to feel good about healthcare system. As professionals, we see the good parts, but the society sees the bad parts. About 58 to 60% of the total expenditure on healthcare in the country is out of pocket. At least about 55% out of pocket. No government coverage and no private insurance or some other insurance. Because remember, those who believe that health insurance is a solution, the total health insurance premiums of India in private sector, private insurance, I'm not talking of employer insurance, I'm not talking of the government programs like Arogyasri. It's only about 28,000 crores annually, the premiums collected. And the insurance claimed is about 16 to 17,000 crores annually. It's peanuts. The expenditure on healthcare in the country, nobody knows that. We keep changing the numbers, but it's reasonable to assume it's about 4%, because it's the one area where governments over the years are reducing the healthcare expenditure. It's nonsensical. We all know, anecdotally, healthcare expenditure is going up, not down in the country. Because government is spending the same 1.1% of GSDP on healthcare, one of the lowest in the world, the lowest for any significant economy in the world. About 70% by the states, about 30% by the union. Because they are shown up in poor light, they are trying to reduce the overall expenditure in the country on paper to show that they are meeting a significant part of the healthcare expenditure through the government. I think the evidence does not support it. Probably about 4 to 4.3% is what we spend on healthcare in the country in total. And about 55 to 60% of it is out of pocket. No other country has this problem. Insurance will not help beyond a point except for people like you and I, because the total number of people covered by insurance in the country, by private insurance, is only about 45 million people. 4.5 crores in a population of 145 crores. 85% of the people of India, the working population of India, please remember, they are in the unorganized sector, with low skills, low wages, without any security, eking out a precarious livelihood, and always on the margins of survival. That's the reason why there is so much of descent into poverty when there are healthcare challenges. You put them together, you see that the profession is doing well. Medical technology is doing better. There was a time when we were kids, or even in medical school, you wanted a coronary bypass, you had to go to US. I think one of the most prominent Telugu persons who went to US at the time for a bypass was Sri Akini Nageswara, ANR. And he used to talk, about how it's actually a new life, your heart has stopped, your lungs have stopped, and evocatively he used to explain. Now, I think in Hyderabad alone, we are doing about 100 a day. As late as 1990s, late 1990s, or maybe early 2000s, the Prime Minister Atal Bihari Vajpayee, he got a knee surgery done, the first knee replacement in the country. And the team had to be flown from Britain, and in a plane they landed in Mumbai, and he got that done. Today in Hyderabad alone, we probably do about 150 a day. So there's no question, professionally we are doing far better. We made many things inaccessible to most people of India now accessible. But the other part of the reality is there too. So what can we do? Let me very briefly summarize. We all know the challenges. What's happening in our hospitals? You take AIMS, India's premier public sector hospital. The daily outpatient load is 10,000. 10,000 outpatients a day to an apex tertiary hospital in the country. The highest number for any hospital in the world. It's not a record we should be proud of. The fact that people flock to a tertiary care center at the apex level every day is an indictment of the system that there is no primary care and family care available. And even our teaching hospitals, if you take all the hospitals associated with Osmania Medical College, probably there are about 6,000 outpatients a day. Gandhi, about 4,000 outpatients a day. These are ridiculous numbers by global standards. Even Mayo's, the world's premier institutions, if they get 500 outpatients a day, it's a phenomenal number. There's a colossal failure below tertiary care. The private sector is doing a phenomenal job, and our finest doctors, they have learnt the best techniques in the country and abroad, and they are giving us back in this country. But the fact that there is so much of a rush for the tertiary care is actually an indictment of failure, not a sign of success. And with the epidemiologic change in the world, we were hearing from the speaker's lounge or the faculty lounge there, the presentation on diabetes or many other problems. Increasingly, we have diabetes, hypertension, heart disease, and of course, malignancies. They are increasingly becoming prominent. There was a time when we thought these were not important. We went to outpatient clinic, in Guntur or someplace, it's all infections and some standard things. Whereas today, infections, the mortality has come down quite considerably. We have to still bring it down. But mortality and morbidity today is not because of infections in the large part. It is because of the non-communicable diseases. As with aging population, with bad lifestyles and bad diet and so on and so forth, these are becoming important. And without a proper primary care system, both diagnosing early and managing the cases, and acting as a gatekeeper to the tertiary care system, we're not going to have a viable healthcare system in the country. We're not going to be able to serve the people. And today, if you look at the numbers, again in India, numbers are very hard to come by. The per capita, per year, outpatient consultations in India are 0.5. That means only 1 in 200 people is going to an outpatient clinic in a year in the country. Whereas the minimum norm for an acceptable level of primary care and family care is at least 2. Many countries have 4. 4 I think is a reasonable number. Some countries do 12 or 13. That may be excessive for us. And for 70 to 80% of in 70 to 80% of the cases, the first point of contact in outpatient clinic is not with a qualified medical doctor. It is with an unqualified rural medical practitioner. Some of them may actually be reasonably okay, but many of them we know what it is like. Now, in the year 2024, in the 21st century, this cannot be taken as normal or acceptable. 50, 60 years ago, maybe yes. But today, unacceptable, particularly when you have 15 lakh plus doctors, annually adding another 1,20,000 or so to the Medical Council registration in the country. What needs to be done? Government is necessary, but it is not the solution. Without government funding, there is no way we are going to be able to extend health care to the bulk of the people of the country. But government delivering is a disaster. We must separate provisioning with providing services. Let me place before you a simple model which we could consider. If you expect the doctors to go after that kind of training to villages, it's absurd. Villages cannot afford them and doctors will not get a decent livelihood. The quality of life is not good enough and economies of scale do not allow it. So what we should do is create a pool of doctors in a small town. Let's say serving a population of about 100,000, the town plus the villages and small towns in the surrounding area within 10-15 kilometers. Just imagine, have a mental picture in your mind. Many of us come from villages, so I'm sure you can easily imagine, relate to that. 100,000 population are thereabout. I'm assuming about 1/3 of the people anyway will not depend on government because the trust in government is gone. When we were medical students, government hospital was the best hospital. It was the only hospital. Today, it's only the poor who go to government hospitals, let's face it. So only 2/3 at the most will avail that, which is a good thing actually. If the others take care of themselves, the burden is reduced and the congestion is reduced, so it's okay. So maybe 60,000 people will utilize it out of 100,000 population in that area. Now, 3 things we can do, and we already have experience. If you have a pool of, let's say, 10 or 12 physicians, pick up young doctors, give them a bit of orientation in family medicine, because we are taught about rough and rumbling mid-diastolic member or a murmur of mitral stenosis and something else somewhere else. No, these are standard clinical staple, but not the day-to-day problems that the patients come to the physician with, particularly family physician. So a bit of orientation for a month or so. They are trained people. There are 10, 12 people having their own clinics. Now here is the key. There must be competition among the providers. There must be choice available to the consumer. That is the heart of it, because if you believe that more and more doctors are recruited by the government and somehow the quality of care will improve, I don't know what you believe, but my experience taught me that it's an unlikely thing to happen. Occasionally, locally, when somebody pays attention, somebody is genuinely committed, some good things may happen, but that's not a system. That's the exception rather than the norm. So competition and choice, but fully funded by the government. We can have variants of the model. Those who can afford a little bit, we can ask a small fee to be paid, so that if you pay, your voice will be stronger. You will hold them to account. But that's a secondary issue. In a country like India, when everything is now increasingly free, to ask for this outpatient cost, even a small part of it, to be borne by individuals, politically probably it's very difficult. But basically, you have a model where competition and choice work. Now, why should the doctors come? A, the model, without going into details, I can tell you, guarantees about 1.5 to 2 lakh rupees net income to each doctor. For a young medical graduate, and believe me, some of you may be familiar, some of you may not be, most of the young medical graduates in India are deeply distressed. They don't know what to do next. The postgraduate opportunities are very limited, particularly in clinical sciences. Out of the 120,000 or so are graduating, there are only about 35 to 40,000 postgraduate opportunities, most of them in ramshackle colleges. We are increasing the number without adequate facilities or teaching. The rest of them don't know what to do. Some go to non-clinical subjects or pre-clinical subjects, but many of them are in despair. Some of the finest young people are going into medical science. They're coming out as depressed individuals, disempowered individuals who are theoretically very sound but who have no practical knowledge. Now, once you guarantee, after a bit of orientation, a decent income, and then they get experience and training. And third, already incentives are available, we can extend that incentive. For postgraduate training, this will count to giving some weightage. So, it should not be a problem to get these doctors. They'll serve 2-3 years, and whenever they want to do something else in life, they can move on. A pragmatic approach. But along with outpatient clinic, unless there are diagnostics and a pharmacy providing medicines, it will not work. And already, luckily, we have the systems in India. We only have to adapt it across the nation. Andhra Pradesh has done a remarkable job of having a free diagnostics. They involve the private sector. By all accounts, I talked to literally hundreds of doctors and patients. They're all very happy with the diagnostics outcomes, because doctors can make a clinical appreciation of the diagnostic reports and the clinical correlation, and done very timely, professionally, very competently. Similarly, Tamil Nadu has come up with very high quality distribution of drugs, free of cost to the people. And increasingly now we are going for generic drugs, Janaushadhalaya, etc. are coming up. So you only have to adapt them on a big enough scale to make an impact. But above all, these primary healthcare clinics, the family practitioners' clinics, must act as gatekeepers to secondary and tertiary care. That is the key. Unless it's a life-threatening emergency or something, we cannot allow the hospitals to be overcrowded with primary care problems. That is the deal. Now, all this is going to cost a relatively small amount. If you are spending now 1.1% of the GDP on healthcare, 0.5% of the expenditure, 0.5% of GDP, we can establish this system for the whole country. In the first instance, we'll probably do about 100,000 physicians in about 10,000 centers. And if the demand is good and if the politicians understand the value in terms of the vote, we can expand it. That's not a problem. But at a very low cost, affordable cost. The outpatient clinics, diagnostics, and pharmaceuticals together will cost only about 0.5% of GDP, and our GDP is growing very fast, about 7 to 8%. And nominal GDP is growing at 12%. And therefore, even 0.5% will significantly escalate the resource, enhance the resources. Then only one thing I would like to say about the tertiary care. I will stop at that. We are doing a remarkable job in this country of making tertiary care accessible to people. But global experience shows that eventually tertiary care is going to be incredibly costly. Even now, I don't know how really many hospitals are bringing down costs. It's not sustainable. That's the reason why in the Aragyasri, while many people entered initially, many reputed hospitals are walking out of that. Not only are there no payments in time, but even the costs are not met in many cases. And you can only do this much as charity. Because by definition, tertiary care in modern technology is expensive. Even if the doctor's time is less expensive in India, more valuable but less expensive in India, the physical infrastructure and the diagnostics, an MRI or a PET scan or a a stereotactic radiotherapy unit or something else, they're outrageously expensive. We're not cutting costs there. I don't know about the numbers, but I'm sure AIG must have cost about 1.5 to 2 crores per bed. And today, you cannot build a decent tertiary care hospital in the country without spending that kind of money. And you spend that kind of money, you can't simply bleed. Even if you're doing at cost, there is a cost attached to the financing cost and the doctor's cost and the consumables and so on and so forth. So you cannot bring down costs below a certain level in tertiary care. Therefore, the government must step in, at least in the old medical colleges, about 400 of them. There are, I think, now 1,200 or so. The old medical colleges, which are probably typically have about 1,000 beds, but are neglected, dilapidated infrastructure. There, I think a significant infusion with public-private partnership. There are ways, there are models of doing it. Private sector can fund it and manage them with an assured return guaranteed, so that the initial capital infusion is not necessary from the government. These are financing models. Let's not worry too much about that. But the point is, with a bit of effort, we can improve the infrastructure and then drive most of the non-paying patients into those hospitals as much as possible to make them more effective. Already they are receiving, as I mentioned, thousands of outpatients. You only have to make them more effective and meet the infrastructural standards required in a modern tertiary care hospital. But and this is the last point I want to make. The challenge of training remains. When we were trained by people like Dr. Bhaskar Reddy and the other colleagues, the finest doctors were in the public health system and in the teaching institutions. Legendary people like Dr. Kodanramaya, Dr. V. Satyanarayana Murthy, Dr. Bhaskar Reddy, and many, many others, Dr. E.N.B. Sharma, Dr. Subhadra Devi, exceptional people. Today, increasingly, the public sector is not attractive for the finest doctors. You have to really think hard to think of one high-quality doctor of national and global reputation who joined government as a professor. An occasional person may be there, but it's an exception, a rare exception. Some of the finest youngsters are going into medicine. The competition is enormous now. The NEET exam, early MSET, this, that, and they're going through 2 years of torture preparing for that and all kinds of things. And theoretically, they're very sound because they know how to pass exams. In the olden days, as Dr. Somaraju mentioned, the professors had to be very kind. Dr. Bhaskar was particularly kind and he passed all of us, whether we knew much or not. Chided us a little bit and said, look, you must know a little better. But these kids actually know, they know how to pass exams. And they theoretically, many of them are reasonably sound. But near zero, and I'm sorry to say this, near zero practical experience. They come out disempowered, depressed, unhappy, underconfident, not knowing what to do after going into one of the finest professions in the world. It's a disgrace what we're doing to our young medical graduates. The quality of training we have to improve, and there's no way government can improve with the government human resources. Dr. Somaraju and I were discussing, and Dr. G.N. Rao. We used to have honorary professor system, which worked pretty well. It's such a strange thing that 50 years ago, 60 years ago, we had more flexible and more innovative systems that served the students and the profession. And today, we give up all those things in the name of modernity. Now, there's no way Dr. Nageshwar Reddy or Dr. J.N. Rao, Dr. Somaraju will become a government teacher. Impossible. But I'm sure every renowned doctor wants to be a good teacher. If we create flexible models, give X number of hours. It's not for the money they go. They go in order to be able to teach. That joy, that excitement from Osler's days and all the great medical teachers, it's always a part of our life. But make it flexible. Make it on their terms. And give the infrastructure and other things. Significant improvement will happen because now we are dealing with the best professionals, inspiring professionals. Medicine requires inspiration as much as knowledge. And then change the examination pattern. On paper, the exam is the same as it was when we went, and that was excellent actually, 50% theory and 50% clinicals. But clinical examination was taken very seriously in those days. In my batch, I remember, half the students failed in medicine, general medicine. in the clinical part of it. It was taken very seriously. So unless you are really proficient in clinical skills, the chances of your passing are dim. Whereas today, you don't need to do practically anything. You don't need to know how to examine a patient to get a first class in medicine. So simply embrace something like the British model of objectively structured clinical examination, and many of you are familiar with things like that, or some other better model, where on paper what exists is in reality implemented, that clinical skills are rigorously tested, without putting undue burden on the student, actually giving them, empowering them. If those two things are done, objectively structured clinical examination or equivalent of it, and with the finest private doctors in the private sector, finest experts, becoming part of the teaching faculties. But in a flexible model, not as government servants, but on a contractual basis with part of the time they give there. I think significant improvement is possible because the input is very good. Even today, the finest human resource is going into medical profession. All this together will cost under 0.8% of the GSDP. I remember long ago when I was in the National Advisory Council, I pushed the system very hard to come up with a model something similar to this. I remember the day I met the Planning Commission to pursue this very vigorously with the Deputy Chairman of the Planning Commission, the member concerned and so on and so forth. The same day Dr. Srinath Reddy was there along with Rajat Gupta trying to pursue the Public Health Foundation. When I made a plea, Montek Singh Ahluwalia said, Jay, you're being too radical. I was only asking for a decent, half-decent healthcare system. Whatever I mentioned will not make our healthcare system fantastic, but it makes tolerable. It makes decent at an affordable cost. It's easy to implement. And we can further improve it later. So we came up with a tepid National Health Mission. I was the architect of that, but no, beggars can't be choosers. You have to take what the system is willing to give you because those in power ultimately make decisions. NHM is better than nothing, but it's nothing compared to what needs to be done. India is now ready. You cannot have economic growth without a decent healthcare system available to people. Not only is it a matter of pride and necessity, it's also economically a necessary thing. Because productivity being hurt, if you take the disability adjusted life years lost every year, for 100,000 population in India, we're losing 49,000 years. Any self-respecting country loses about 18 to 19,000. Because elderly people anyway, and some amount of disability which is inherent in epidemiological profile, we cannot stop. But the balance 25 to 25,000 life years per 100,000 population are fully avoidable. And that is an economic issue. Hundreds of billions of dollars are lost. Productivity is undermined. And if you design a decent, half-decent healthcare system, you can probably employ another 10 million people in medical profession, directly and indirectly. Right now, we employ the lowest number of doctors in the medical professionals, not merely doctors, the whole spectrum across the spectrum. In public and private sector, we only employ about 3.6 million people in the whole healthcare structure. Take UK. UK, with about 4% of India's population, about 4.2% or so of India's population, employs 1.6 million people in healthcare. Now, we can't reach that level. We don't need to. But we can easily, because health is an incredibly important thing world over. It accounts for a very large part of our national life, the quality of life and productivity. So there are many externalities, many things that will happen automatically in terms of economic growth. And therefore, we can sell it to the policymakers not only as a healthcare issue, not only an issue of eliminating avoidable suffering, but also one of economic growth and job creation. But the healthcare professionals must be the champions of this. Today, the moment somebody comes to a tertiary care private hospital and sees the bill, the person is angry. That person feels that the doctor in the white coat and stethoscope there is the guilty party. They don't realize that we actually have the lowest cost healthcare in the world. They don't realize that we actually have the lowest cost pharmaceuticals in the world. But all this is for us, but they don't care. For them, it's hurting. And therefore, the mistrust of the medical profession is growing. And we all know only too well, no matter how advanced we are scientifically, half of medicine is the trust in the physician. If you mistrust the physician, if you are unhappy, chances of recovery, chances of improvement and healing are much less. So the patient is losing, the profession is losing, the country is losing. I ask of you, we owe a debt of gratitude to people like Dr. Bhaskar Reddy and all those great teachers in this country and abroad. I browsed through Dr. Somaraj's book recently, where some of the finest medical teachers from Hippocrates to Osler, he gave a glimpse of those people's lives and ideas to young medical students. We owe a debt of gratitude to them, and I think the least thing we can do is really bring back that spirit of healthcare. Make it a part of the community. Make everybody access it. In this day and age, healthcare cannot be a luxury. It has to be a part and parcel of our governance structure, our social structure. Many of you are working very hard. I know about Dr. Nageshwar's work in screening patients for gastroenterological problems in many districts, etc. But these are all of charity. They are not scalable. You are going out of your way to spend enormous money and devote enormous human resources for something which the government should be doing with our tax money. So to think that this is a substitute is not right. Certainly the private sector will come in, certainly the philanthropists will come in, charitable institutions will come in. In India, there is no dearth of charity. But if the state does not do its job well, does not take it seriously, and does not learn from the past experience and then innovate, institutionalize better models, and make it replicable across the country, we continue to struggle. We continue to feel bad, doing better but feeling worse. And until a structure really evolves in the manner, something equivalent to this, we can improve that. I'm sure there are better ideas along. Until that happens, healthcare outcomes overall will not improve. If you notice, despite significant expenditure now being incurred in tertiary care and secondary care, hospital care, through government programs like Arogyasri, Prime Minister's Ayushman Bharat and so on and so forth, there is no tangible evidence of improvement of healthcare outcomes. These are two different things. Yes, the burden and the pocket of the poor has come down to some extent. But that's only one part of it. The outcomes have not significantly improved. I think we can make this happen. This is doable. This is politically attractive. Dr. Rajasekhar Reddy proved that if you take up even bits of healthcare, you can make them politically attractive and meaningful in terms of outcomes. So a time has come when we make healthcare one of the central pillars of politics and political discourse. It's one of the ironies of a democratic politics in India, in one of the poorest countries with poorly served healthcare system. There is hardly any serious debate on healthcare as part of the political discourse. I think the medical profession must stand up, proud and tall for the work they have done, and must use their lung power, their credibility and their influence to be seen as champions of a viable healthcare model in the country. That, I think, will be a fitting tribute to the great teachers that we have, like Dr. Bhaskar Reddy, on this centenary occasion. Thank you very much for your kindness and for your patience.